Lab values. What are lab values? It's one of those things that a student of any clinical sciences starts off with dread. Oh, I have to remember lab values. I have to know lab values. What are those? So this presentation will hopefully ease your mind about what lab values are and what you need to do to understand the concepts of lab values. So we will teach you lab values under the heading of the clinical laboratory, which is where tests are done to find out lab values. Let's get started. For CAPT's directives, these are the objectives of your lab values lecture. There are two associated resources with this presentation that you must use for your self-study of the lab values section. So there is a SWAY and there is a PDF handout. The SWAY is linked here, but it will also be available from Teams in the self-study section of the pathology course. Go to the SWAY and look at all the written as well as video materials explaining different areas. In 2008, the Academy of Acute Care Physical Therapy uh, put a team together to review what would be essential entry-level practice requirements in terms of knowledge of lab values. That document became a standard for physical therapy students and early practitioners using it to inform them of what they needed to know, both reference ranges as well as interpretive guidelines. In 2017, this document was updated, and that updated document is the current available standard that you need to achieve. That document has been provided to you in the team's self-study channel as well as in module 1. If you go there, you can download a copy of this PDF. This PDF is also available for free from the Academy of Physical Therapy, acutept.org, and it has been made available to non-members as well. Just to give you an idea, the membership for annual membership for an acute care section student membership is $9. It's less than 2 cups of coffee. I strongly urge you to consider getting a membership for the resources that the Academy publishes. This slide has been provided to give you guidance on how to study for lab values. This presentation itself is a broad overview of the lab values science. The details of this science has been compiled into the SWAY that I just spoke about. You go to the SWAY available from Teams self-study channel and study in more details of each one of these lab values that we are going to discuss below. Plus, it also gives you videos and explanations about the relevance and interpretive guidelines on these topics. Individual lab value references was deliberately removed from this presentation to keep it concise. Instead, they are presented to you in the handout resource from the Academy of Acute Care Physical Therapy that you must use to inform yourself about those items. I do urge you to consider comparing these lab values to the relevant sections of physiology to kind of help build your construct of how physiology alterations go step in step with the lab value alteration, because that's how we know physiology is altered. And additionally, to help you along, I have given you the guides to what exactly you should focus on in each one of these major lab value sections that we discussed below. In this section, let's get an overview of what is lab testing, why should we do it. Lab testing is based on the construct of defensive medicine. To understand that, let's go back and figure out, why does a patient come to medical care? Patients do not come to medical care usually with a diagnosis of a disease, but because they are having some kind of symptom set related to disease. When patients present with symptoms, it's often not clear which organ system, or a combination of organ systems is malfunctioning, or which external agent, such as an infection, is causing the disease symptoms, the clinical manifestations that you have learned earlier. Specialists in medicine and in healthcare, including physical therapists, are often consulted without a full understanding or diagnosis, if you will, of what is the underlying disease or disorder. They are just consulted because the patient is having clinical manifestations of disease. It becomes imperative to have a full understanding of causation of the clinical manifestations of disease. When we see patients based on intrinsic knowledge of the behavior of a disease that we know because we read about it or because of our prior experience, often we have a fair amount of clinical suspicion of what is causing the symptoms. However, in defensive medicine, it is imperative to have a concrete diagnosis before treatment is started. Now, the clinical suspicions sometimes are very important even before diagnosis is confirmed. This becomes most important when there is an urgency of health deterioration. For example, somebody presenting with very high fever needs immediate treatment, even though we don't know what kind of treatment to be done. So some kind of a stopgap measure is taken before we are confirmed of the disease underlying the clinical manifestations. This um, uh, this stopgap treatment, just to make sure a patient doesn't continue to worsen, is known as empirical, EMPIRICAL, treatment or management. So, beyond empirical management, we still want to confirm what disease or disorder is underlying the clinical manifestations of disease. Therefore, we seek different types of investigations to confirm our clinical suspicions, and that forms the basis of investigations that can be done. These investigations run a gamut of different types. So, investigations are therefore processes that are linked to differential diagnosis, or simply the word differential. You can go on to the sway associated with this lecture to read more about differential diagnosis. Now, differential diagnosis is the cornerstone of accurate, final diagnosis and evidence-based medicine. I have provided you with further information on the process of differential diagnosis in the sway that is associated with this lecture. So, this term, investigations, that I mentioned can take various forms. Two common forms of investigations are laboratory testing, and this involves the presentation that is primarily concerned here. The other type of investigation is imaging. Imaging is not part of this presentation. So investigations for the clinical manifestations of disease or establishment of a differential diagnosis requires different kind of investigations, and this presentation will only deal with the laboratory testing part of the investigations. Now, apart from differential diagnosis, lab values also offer a number of other information that can be found in the SWAY that is associated with this presentation. The importance of understanding the principles for selecting and ordering the most rational lab tests on a specific patient is heightened in the current age of managed care, medical necessity, and outcomes-oriented medicine. The days of a shotgun approach to ordering lab tests has of necessity been replaced by a rifle or targeted approach based on an understanding of the test's diagnostic performance and the major legitimate reason for ordering a lab test. Such an understanding is critical to good lab practice and patient outcomes. So, lab tests are clinical procedures performed in a lab on a sample of blood, urine, other body fluids, or tissues. Results of these tests reveal intrinsic performance and intrinsic physiological homeostasis of a patient's body. The results of the test will show if a person is within the normal lab reference values for a particular finding. Abnormal values are specific or it can be non-specific. Specific abnormal values point to an organ or organ system disorder or pathology, making it possible to accurately diagnose and therefore treat a disease. Non-specific lab values are indicative of a pathology in progress, but may not be able to tell or demonstrate which specific abnormal process is occurring in organ and and it will not tell which organ is contributing to that abnormal value. So values obtained from a laboratory are not absolute, but they are expressed in ranges. So it is not one number, but a range. The normal range of lab values is usually dependent on reagents used by the laboratory. Hence, different laboratories may vary somewhat in their lab estimation of normal versus abnormal. So that is usually provided. All lab values are stated in the normal ranges for that organization in the report. It is of utmost importance not to be swayed by the number, but be aware of the relevance of the abnormal value. So this comes in useful when you try to understand with a specific example. Too low of a certain substance in the body, it can cause a different disorder, versus too high and it can cause a different kind of disorder, and both may be very dangerous for the human body. So one example is the value we know as INR. In INR, if it is less than its normal range, it is less than the lower value of the normal range, a person may have the risk of clotting up of blood within their bloodstream. That can lead to conditions such as heart attacks, strokes, and many other clotting disorders within the body. On the other hand, if INR values are really high, higher than the normal upper range, it will lead to risk of too much bleeding. So people may bleed more than normal and may have bleeding disorders such as, again, bleeding strokes, bleeding inside the internal organs such as the GI tract, and so on. So it is important to know the range and the disorders associated with the lower part of the range and upper part of the range. So if it is less than the lower part or more than the upper part, what is the relevance of those numbers? So lab tests are used for the purpose of screening, for the purpose of diagnostics, and the purpose of monitoring the progression of a patient. So examples are provided on the screen. Now, PTs do not have prescriptive authority yet in the United States, but it is changing because in other countries it is present or developing as well. We can request the physician to order specific lab values if we suspect that there is an underlying condition with the clinical manifestations of the patient. The process of requesting and reviewing lab values is dependent on both technique as well as finesse. That's why it is both art and a science. So it requires knowledge of disease, it requires time, and it requires experience to learn how to do targeted requests for lab values. Now, there are many lab values that are reported from a single sample of body fluids and or tissues. We do, however, have to have a very good idea of what we are looking for. It is important to realize that we look for specific lab values based on suspicion for specific underlying disease. It is not helpful to go through each possible lab parameter and may contribute to over-investigation and investigation fatigue. We are going to look at the phases of lab testing and the limitations of lab testing in this section. The lab testing cycle begins with the ideation of the clinician when they think that a certain lab test is needed, and also involves the time that the appropriate patient sample is obtained, for example, a blood specimen, and the result of the testing is returned to the clinician, often called the vein to brain turnaround time for the test result. This cycle consists primarily of three different stages: the pre-analytic phase, and then the analytic phase, and then the post-analytic phase. So the pre-analytic phase deals with the patient's preparation, sample collection, sample transport, all of which offer potential pitfalls in failure of a good sample reaching the laboratory. It is strongly recommended for standardization of all of the above processes with strict guidelines for the process. The analytic phase of entire cycle deals with the actual analysis of the sample in the lab. This is the period that you're waiting for the lab results to come back. And then you get into the post-analytic phase, and this is where a lab report is generated, delivered, and interpreted at your end. Once it is interpreted, it also includes the clinical response to the interpretation as to what to do next. PTs are going to mostly deal with this post-analytic interpretation of lab data for now. It is important to know your lab values. It is important to use that to inform your practice. But at this point in time, I would be remiss if I do not mention that it is also important not to treat the numbers, but to treat the patient. Treat the patient and not the numbers is one of the most valuable pieces of information you can take away. So sometimes numbers may be an indicator, but not necessarily the driver for treatment. And that is why intelligent analysis by human beings is important. So the question arises is, are there some normal lab values? So yes, normal lab values are a set of upper and lower limits or reference ranges generally given as a range of more than or less than signs, since normal values may vary from person to person and laboratory to laboratory. And the presentation here is concerned with the adult lab values. The age range of adult lab values cover the young adult of 18 to 44 years, middle adult from 45 to 65 years, and the older adult of more than 65 years old. People reach their lab values during their young and adult years. This presentation does not discuss pediatric lab values at all. Broadly speaking, there are 4 different end goals to evaluate lab values. So, um, for screening purposes, what are the chances of a patient having a certain disease? Um, what are or identify the changes in health condition prior to the onset of symptoms. For example, in cases like prostate cancer, PSA will detect the possibility of the onset of prostate cancer, and then phenylketonuria and the presence of it would indicate the possibility of the onset of diabetes. So these are for screening purposes. For diagnostic purposes, it helps us discover the causation of symptoms. Why is a person demonstrating a given symptom? For example, if a person's lab values show troponin, then there must be an underlying myocardial infarction, death of the muscle cell of the heart. Similarly, the presence of CKMB, creatinine kinase MB, would indicate breakdown of muscle, as in rhabdomyolysis. Similarly, glucose levels would be elevated in diabetes. The next thing is confirmation of a diagnosis. I think this person is having a quote-unquote X diagnosis. Let me check if that is true. When you instinctively know the possible causes based on likelihood and urgency, but want to be certain, then it is another reason to do lab values. Finally, for treatment purposes, you plan for treating of a disease or a condition, you evaluate the response to the treatment, and then for monitoring purposes, such as monitor the course of a disease over time, like for example, BNP levels in heart failure. Lab values require units of measurement. Without units, it is not uh, it is not a complete set of information. So lab values are usually presented in either milligrams per deciliter, grams per deciliter, millimoles per liter, and so on. Despite electronic documentation having coming in, there is a very well established international handwritten convention of recording and reading lab values. It must be learned by every practitioner because not only is it important when electronic documentation crashes, but also it is important to be able to read another practitioner who presents their data in the handwritten convention, and therefore it is still used, and you need to learn this. Now, the handwritten conventions are shown here, and you will notice that the first one here up here, the first one is for blood values: hemoglobin, hematocrit, white blood cells, and platelets. The second one is reporting prothrombin time, tissue thromboplastin time, and INR, which is international normalized ratio. This one is blood chemistry. It is showing electrolytes and other chemistry like sodium, potassium chloride, carbon dioxide, blood urea, nitrogen, creatinine, and glucose. And the last one is showing calcium, phosphate, and so on. It is important to not only know the ranges, but it is important to know when these would be ordered, and of course where they belong. If we just give you the diagram, you need to be able to pick out which one is the information that you need, because all you will see there in actual documentation is the number, and you have to figure out what that number means. Recall that lab medicine is usually divided into three main phases: pre-analytical, analytical, and post-analytical. Data has shown that problems related to specimen collection are the main causes of pre-analytical errors. This may be as high as 84% or more. The complete elimination of lab testing errors is unrealistic, especially those relating to pre-analytical phases. Most of these processes are not under direct lab supervision and are harder to control. So there are these factors that will affect lab results. Some of these factors are limiters that are included here in the slide, but more details such as age and race and others are included in the SWAY. There are certain factors that are seen most of the times in pre-analytical phase: loss of sample integrity. So loss of sample integrity is where the sample is, we are not talking about getting lost, but it is that these samples are tainted, they are less than optimal for testing. So one of the reasons why a sample may be tainted or abnormal and integrity is lost is seen in blood samples. So hemolysis is the breakdown of blood products. Most vascular cell damage that happens occurs during the actual process of phlebotomy, the actual introduction of the needle into the vein. This is by far the most frequent reason for specimen to be tainted and rejected. According to the American College of Pathology, it occurs more frequently than insufficient specimens. So insufficient specimen is where not enough blood has been made available, so not enough blood has been drawn. So in vitro hemolysis can occur during phlebotomy. In vitro means uh, while the actual blood is being pulled from the vein, and it can happen right then, and it can cause rupture of the cell membrane of the red blood cells and leakage of the pigment hemoglobin into the surrounding fluid. And it can happen from other improper specimen collection, wrong needle, excessive mixing of the blood sample, inadequate storage temperatures, or rough handling during transport. So hemolysis can also happen when it is being drawn from a peripheral IV catheter, a catheter that is already there, but it can happen from there as well. It can also happen in autoimmune hemolytic anemia or as a transfusion reaction. So the best solution for hemolysis uh, is to recollect the sample. But if it is not possible to recollect the sample, then results are reported with the error and is noted to the clinician by the lab technicians. The other type of loss of sample integrity that is pretty common is lipemic uh, plasma. So lipemic plasma is called so because of the presence of large lipid particles that include lipoproteins and chylomicrons, which are breakdown of fats. As a result, these samples look white and turbid and may result in the prolongation of coagulation results. So coagulation tests are done to ensure or verify how long does the blood take to clot, and is used to evaluate diseases of bleeding or diseases of clotting. So a turbid sample should give rise to suspicion that there was a significant amount of lipids present in the blood at the time of the draw. This can also happen when people take a huge fat heavy diet, like for after ingesting a very high fat content steak, will also lead to this. Now, icteric plasma is high levels of bilirubin in the blood. So normal levels of bilirubin is about 0.5 milligrams per deciliter. But in cases of hyperbilirubinemia, which is seen in failure of the liver and in certain other disorders, plasma will become affected and is shown. So the word icterus means turning yellow, and that is what is shown in the picture. Icteric plasma samples have a high prevalence in samples from patients in the ICU, as well as patients with gastroenterological diseases involving the liver, as I mentioned, also in surgical patients as well as pediatric patients. So concentrations of bilirubin greater than 2.5 milligrams per deciliter can lead to icteric plasma samples. And of course, it can alter anti-thrombin levels, which means it's thrombin being a protein that helps in blood coagulation, which can be prolonged. And that's an icteric sample. Laboratory tests look for reference ranges of various parameters, which means there is a lower end of the normal range and an upper end of the normal range. Not only should we know what are these normal ranges, but values that are out of the range are usually put in red, suggesting abnormal results, and also indicates whether lower than normal or higher than normal. It is very erroneous to get into the mindset of thinking, oh, this is low, or oh, this is high, because that really means nothing. While that is the first step or stage of thought, it is absolutely disastrous to just leave it at that. Instead, you should be thinking, what is this low value related to? What is the impact of this low value on the patient? Or what the high value might be impacting on the patient? As an example, let's take the item hemoglobin, which is a pigment which is present in the red blood cells of the body or the blood. This hemoglobin is evaluated in the hematology panel along with hematocrit, which we just referred to below. So a low hemoglobin hematocrit value is an indicator for possible bleeding somewhere, which means the person is losing blood actively, which is what is dropping the value. So this bleeding may or may not be visible, but it needs to be paid attention to. Or if the person is not bleeding, then what else could be causing the drop in hemoglobin? So one of the other thoughts is there a defective production of hemoglobin happening, which is very typical of diseases such as blood cancers. Okay, for example, myelodysplastic syndromes in which the bone marrow fails to make adequate normal amount of blood cells. Now, since hemoglobin's job is to transport oxygen where? Everywhere. What would be the impact of a low hemoglobin on the function of the patient? On the other hand, a high hemoglobin hematocrit value happens in disease such as polycythemia. Now, what would be the impact of high hemoglobin and hematocrit uh, as seen in polycythemia on patients? So these are valid questions to answer. While I can answer them for you here, but this is for you to discover and really apply it in various diseases and disorders and think about the impact on the patient's health and function. Now, this is the way that you need to think with evaluation of lab values. That is why just looking at the results in a lab is relatively useless unless you make sense of what it is telling you. And no, the responsibility is not of the physicians alone. Imagine yourself reviewing a set of lab values right after they were reported, right before you are going in to see a patient, but before the physician has had a chance to review and interpret the results. So would you disregard the results because you don't know or you have not given thoughts to it? Or would you want to see your patient later after the physician has reviewed the patient? And I will tell you that there are therapists who do that, but then they claim to be a doctor. And that is where the rubber meets the road. Are you a doctor if you cannot interpret a test result? So now we come to the section of clinical chemistry. Clinical chemistry, also known as clinical pathology, clinical biochemistry, or medical biochemistry, is the area of chemistry that is generally concerned with analysis of bodily fluids for diagnostic and therapeutic purposes. It is an applied form of biochemistry and is not to be confused with medicinal chemistry, which is used for research of drugs and for development of drugs. The discipline of clinical chemistry has been around since the late 19th century, and at that time, simple chemical reaction tests were done on various components of blood and urine. In the considerable decades since that or initial practice, other techniques have been developed and applied as science and technology keep on leaping forward. Most um, uh, most of these areas of study involve blood tests and clinical urine tests with extensive support of diagnostic capabilities. So labs are highly automated nowadays, and they can typically produce very rapid results in most of these clinical chemistry investigations. So on this slide, you see a number of broad areas of clinical chemistry. So not only does this show you clinical chemistry, but also it talks about hematology, which is specifically clinical chemistry of the blood, microbiology, and blood banking. We will take a brief look at each one of these as a science, not necessarily the reference ranges. So the common panels that we see in clinical chemistry are shown on the screen. There is a basic metabolic panel, there is a comprehensive metabolic panel, electrolyte panel, lipid profile, hepatic panel, renal panel, thyroid panel. Now these tests are common panels. They actually don't belong to one single area of study. For example, the hepatic panel is part of investigations of gastroenterologic diseases. Renal panel tells you about kidney function, whereas thyroid panel is a panel that can be classified as a endocrine system study. Now, there are hundreds and hundreds of these endocrine system studies alone. We're just bringing out the ones that affect general day-to-day functions a lot, and it will come in useful for your understanding of underlying diseases and disorders. So the basic metabolic panel components are shown on the screen. It looks for these particular electrolytes like sodium potassium chloride, and it also includes reports on carbon dioxide, bun, and creatinine and glucose. So why do we need these? That's an interesting question, but we will continue discussing this before we get into those weeds. The comprehensive metabolic panel includes all the tests of the basic metabolic panel, but adds in tests that are relevant to liver function and especially liver function. This slide shows you the major components of an electrolyte panel, which includes sodium, potassium chloride, bicarbonate, and so on. Typically, when bicarbonate is reported, it also reports carbon dioxide values, as you will learn in physiology. Now, the electrolyte panel is one way to look at water content of the body. Water follows electrolytes, so sodium levels will also determine water levels in the body. So higher sodium levels means higher water. Water goes the direction of sodium. So if sodium is being retained in the body, water content will be high. If sodium is being excreted, that means water content will be low. So electrolyte imbalance overall leads to water imbalance. Water is not directly measured in labs tests, but electrolytes are, and that's one way to look at water content. So what are the things that you want to study for the basic metabolic panel or the comprehensive metabolic panel or the electrolytes panel? You need to know the reference ranges of each of the listed electrolytes. what are the implications of the values if the normals, if the values are less than normal or more than normal. The implication is perhaps the most important thing to study for everything. And what are the circumstances which alter these electrolytes as abnormal? So under what disease condition would these abnormalities surface? And that goes in lockstep with the implications of the abnormal value. So this slide shows you the lipid profiles, or this is the lipid profile test. Shows you the components of lipids that is investigated in the lipid profile. So what do you study for the lipid profile? You study the reference ranges for each of the items listed. Which one is considered good or desirable lipid? Which one is considered bad or undesirable lipid? What are the implications of these desirable and undesirable lipids, and why? This screen shows you the hepatic function panel, and you will see that a major component is albumin, which is protein, gives you an idea of the protein content of the body. And then liver enzymes. Liver enzymes are very important in assessing whether the liver is doing its job or if it is failing. And then ammonia. When the liver is failing, ammonia levels go high up. What is the implication of high ammonia? I'll give you the answer here. If the ammonia is higher than normal, and that means the liver is not able to get it out, it goes to the brain, makes the person confused, and there are other neurological signs that are associated with hyperammonemia, which means too much of ammonia in the blood. So things to study for the liver panels is albumin, bilirubin, liver enzymes. What is the importance of each one of this lab item? And what would an abnormal value indicate to you? That is, what would it inform you about this patient-specific state of health? This one gives you the renal function panel, and these are the tests that can be done from both a urine analysis as well as from blood analysis. So some of these are done, some of the kidney tests or renal function tests are done from a blood analysis, and these tests can be done from a blood analysis. Some of these tests can be done from a urine analysis. The the guidelines to study for the renal function tests is the ranges of each one of this in the plasma and in the urine, and what is the implication of these tests? What should you interpret? Should these tests come either either um, in the urine or come abnormal in the urine or the blood? Let me give you an example. Albumin is a macromolecule, it's protein, and proteins do not cross over into the glomerular space in the kidney tubules. So that means if albumin shows up in the kidney tubules, it means there is destruction of the glomerular basement membrane, and that means there is intrinsic kidney disease happening. So typically, urine should not contain any proteins, but then if albumin shows up in the kidney, in the urine, that means it is filtering out from the blood into the kidney space. Similarly, there are other elements of renal function that should be studied. In this section, we'll look at the lab tests for endocrine system. The first one we want to talk about in endocrine related lab testing is the diagnosis of the endocrine disorder called diabetes mellitus. The American Diabetic Association recommends the following tests for evaluating blood sugar. It includes fasting blood glucose that requires 12 hours of fasting prior to sample being drawn, postprandial blood glucose, which is blood glucose drawn after a certain amount of time elapses after food, the glucose tolerance test, which is usually done 2 hours after ingesting glucose, and then the long-term effect of glucose handling in your body, which is indicated by the glycated hemoglobin levels, which is effectively a 3-month average of plasma glucose concentration expressed as percentage, and is an evaluative criteria for avoiding complications of diabetes. Some other hormones are studied for particular reasons when it involves these various areas: adrenal glands, gonads, thyroid, and parathyroid. And each one of these have their own importance and indications. Here is the thyroid panel, which tests for thyroxine, triiodothyronine, and the thyroid stimulating hormone, which is a hormone of the posterior pituitary. So, why do we need to do that? What are the implications? For that you have to read this way. So what do you study here for hormonal labs? Study the diabetes panel. What are the normal values? When are they done? Things like that. Thyroid panel, same thing. Electrolytes, sodium, potassium, chloride, magnesium. These electrolytes we just talked about earlier are regulated by certain hormones. Most importantly, the ADH, or the antidiuretic hormone, but other electrolytes, other hormones as well. What are the implications of high levels of values or low levels of values of each component of these hormonal labs? In this section, we are going to look at the cardiac enzymes. So what are the cardiac enzymes? They are shown on the screen, but let's look at the next slide. So cardiac enzymes and cardiac biomarkers are lab values that specifically inform us about the health of the heart. So these are known as cardiospecific biomarkers. Which ones are those? Those are seen in the cardiac panel. Which ones are those? So we will need to know that. We will need to know when they get abnormal. The most common reason for cardiac panel enzymes to show up, or biomarkers to show up in a lab test of the blood, is when there is damage to the heart muscle. So here are, in order of importance, the four major cardiac specific biomarkers and enzymes. One is troponin, one is CKMB, creatinine kinase MB, creatinine kinase total, CK total, and CK index. Why are they in this order? Well, troponin is the most specific biomarker, but troponin has a number of subforms. So you want to know about that when you do your reading. Typically, there are 3 troponin subforms. Out of these 3, troponin I and troponin T are more specific for damage of the heart muscle itself, which means they're expressed into the blood plasma when there's damage to the heart muscle. The third form of troponin is more related to muscle, troponin M. So M for muscle, and troponin M does not tell you whether it is coming from the heart. In fact, it is not coming from the heart. So if troponin is increased, it does not indicate heart damage, but it may indicate damage to the muscle, skeletal muscle. CKMB is a less specific indicator of heart muscle damage. While it will go up in heart muscle damage, it will also go up in muscle damage, and therefore it is not quite as specific as troponin. But those tests are done to support each other and see if there is cardiac muscle damage. On the flip side, CKMB going up indicates muscle damage and is seen in conditions where there is frank muscle injury or hidden muscle injury. Frank muscle injury is seen in conditions such as crush injuries, whereas hidden muscle injuries is where you don't see visibly an injury, but there is a massive injury called rhabdomyolysis. So in that, CKMB and creatinine kinase total will both go up. So directly or indirectly, CKMB is also tested for in a cardiac panel, but cardiac specific biomarker is troponin. So this screen actually shows you the diagnostic windows in which these cardiospecific biomarkers peak and then disappear from the blood over time. I would need you to review that, not just from this screen, but in actual text to see what is the elevated peak time, which means the time by which the values of a certain cardiac biomarker peaks and then it falls off, and how long does it take to fall off. Those are indicative of muscle damage, cardiac muscle damage, and related issues. These are some other cardiac tests or tests done in cardiac conditions. Homocysteine is a protein, C-reactive protein, another protein, and B-type natriuretic peptide. Each one of these has other important information that it conveys. One of these is the C-reactive protein. C-reactive protein is a non-specific marker of what? Of inflammation. So C-reactive protein goes up in inflammation. It is unfortunately non-specific, so it doesn't tell us why it is raised, but the presence of an increased C-reactive protein in the blood plasma is indicative that there is a definitive inflammation going on somewhere in the body. The B-type natriuretic peptide is nowadays considered one of the most important tests for heart failure, so you would want to look at that, also called proBNP. So this is a guideline for what to look up for cardiac enzymes, which test is relative to which disorder, what is the peaking and dissipation of the enzymes, and what values are representative of normal versus injury. In this section, we'll look at testing for blood gases. So we'll look for oxygen saturation as expressed in percentage. This is the abbreviation under which it is often reported. SaO2 and SpO2, as you will learn in hematologic and cardiovascular physiology, also in pulmonary physiology, you will learn that SaO2 and SpO2 basically talks of the ratio of oxygen bound to hemoglobin compared with the total amount of hemoglobin capable of binding to oxygen. And when you look at SaO2 and SpO2, what is the difference? SaO2 and SpO2 are exactly the same. It gives us the same results. However, the SaO2 refers to blood that has been sampled from an artery, whereas SpO2 is the result of testing the same parameter from top of the skin. So the technology is different, reports the same value. However, SaO2 may be slightly more accurate and is done only when there is present or arterial line, which means a tubing present in the artery of the patient. So the blood can be drawn directly from there. Blood gas parameters, other than SaO2 and SpO2, we look at pH of the blood. pH is indicative of the acid-base status of the patient. And then we look at the carbon dioxide, PaCO2, total carbon dioxide, PaO2, SaO2, which we just talked about, and the O2 hemoglobin, oxyhemoglobin. Now, or the oxygen content of the blood, also called PaO2. The A in PaCO2 and PaO2 is representative of arterial. That means that the blood which is sampled in these patients is not venous blood. You can't do the test here listed here on venous blood, but has to be arterial blood. So what do you look up and what do you study in this area? You look at the normal values of blood gases and what makes these blood gases go away from their normal ranges. And if they did go away from their normal ranges, what would be the impact on the patient? A lot of this information comes down from physiology, so you would want to compare it with physiology studies as you go along and study more. But for the lab quizzes and specific lab quizzes, the values is what you need and a superficial idea of the answers to these questions. Hematology talks about blood studies or the values that we have just or we have talked about previously or not, but it talks about the values of parameters in the blood. So we look at these things in the hematologic panels. This is the complete blood count CBC panel, and it shows you all these elements that are listed here. And consider looking up during your studies the normal ranges for the CBC parameters, what makes them go haywire, what is the implication of a number too low or too high. For example, I'll just give you an example of leukocytes or white blood cells. If they're too high, it is indicative or highly suspicious of an underlying infection in the blood. Now, it probably gets into more complex territory to tell you that sometimes you can have an infection without white blood cells going up, but we are not going to go there at this time. But what we want to talk about is that what makes these ranges go abnormal, get a basic idea of that, and what are the implications of these values being abnormal. So how would these abnormal values impact the functioning of the patient? The next one is blood banking. Blood banking is a science that deals with evaluating the quality of the blood that has been presented for purpose of eventually transplanting this blood. Blood transplants it's a liquid transplant and they're called transfusions. So before a transfusion is done, these things are looked into. So we look at ABO, Rh factor, antibody screening, antibody identification, and cross-matching. So in context, nowadays we are talking about COVID-19 as an infection, and that leads to the body developing antibodies against it. And so it would be done as a part of blood banking to check whether the person has antibodies. So what would you like to look up in this section? What is important for you to study? So what is ABO typing? So you can see that in physiology. And what is Rh typing? What is Rh factor actually? And where does it come from? What is the implication? What is the need for cross-matching? Why does a blood need to be cross-matched? What can happen if cross-matching is wrong? If it is erroneous, for example, if they say that this is this person's blood, it turns out to be, or if they say this blood is type O or type A, and it turns out to be not a type O or type A, then what can happen in clinical settings? That's what you would want to know from this section. Body fluids are analyzed. All kinds of body fluids are analyzed. Yes, some of the most important ones are shown here: urine, cerebrospinal fluid, which is CSF, synovial fluid, pleural fluid, pericardial fluid, peritoneal fluid, semen, and so on. What is the implication of these? So the considerations for looking up, or the guidance that I'm trying to give you to look up, is um, body fluid component reference ranges are part of individual panels and organ studies. For example, electrolytes and glucose, these could be part of endocrine studies. Okay, why do test like urinalysis? When do we test for urine? The answer is to see if there is infection, to see the kidney function by evaluating glomerular filtration rate of certain items that are present in the urine panel or urinalysis panel. And then the presence or absence of glucose. Why is that important? Why is glucose important? Well, in urine studies, glucose should not show up. Same as albumin, it should not show up. But if it does, what does it tell us? And when is it important to test for these fluids? So that is another thing that you should look up. Microbiology studies are done to evaluate for bacteria, fungus, and other infectious agent in the blood, but it is also done to test for infectious agents in the tissues. So all kinds of tissues and blood samples are taken, and they are subjected to many types of staining that tells us what that infective agent is. One of the most common stains to see in bacterial staining is gram staining. There's some bacteria that pick up the gram stain and look a certain way, and we call it gram-positive bacteria. There are other bacteria that are unable to pick up the gram stain, and so we call them gram-negative bacteria. What is culture and sensitivity? I have a slide for that. This also informs us on how to uh, treat those patients. And microbiology testing also involves molecular testing. For example, RT-PCR testing is done for a little known condition called COVID-19. So that is reverse transcription as polymerase chain reaction testing. Now, culture and sensitivity is done to evaluate bacterial infections in blood and urine and CSF and other tissues. So, culture means to identify a bacterial organism. Sensitivity is done to do what is called susceptibility testing to see what kind of antibiotics will kill that bacteria. And that is how we determine what specific drug to use to treat that patient. Obviously, it is done by the physician, but it also informs us as a clinician for intelligent conversation with the entire team. So what do you study in this area? What is the importance of culture and sensitivity testing? How does that impact treatment? And here is something interesting for you to look up. What is empirical treatment, especially in context of infectious disease? And what is the difference between empirical and targeted treatment, again in reference to infectious disease?